Hello and thanks for joining us. We're coming to you from the 2011 American Heart Association meeting in Orlando, Florida. And we have with us tonight Dr. Anne Gillis from University of Calgary, who is also the president-elect of the Heart Rhythm Society, and congratulations on that appointment.
Thanks, Melissa.
And thanks for joining us tonight. Anne and I had a very interesting conversation before the cameras were actually rolling, and we'll try to continue that conversation. It was centered on the PALLAS trial, and I confessed to Anne that I'm sort of a lay person in the EP world, and when I saw this trial, I actually asked myself the question, why would anyone want to utilize dronedarone in patients with persistent atrial fibrillation anyway? So there is a method to their madness, and would you care to comment about that?
Sure, Melissa. In the ATHENA study, which was a randomized trial of dronedarone versus placebo in patients with atrial fibrillation, the investigators reported that dronedarone reduced hospitalizations for cardiovascular events. And a number of the events that were reported were that dronedarone reduced the incidence of arrhythmic death. Dronedarone also is a heart rate slowing drug, and so there was deemed that it might be potentially valuable in the population with permanent atrial fibrillation due to additional rate slowing effects. And in a sub-study of ATHENA, the investigators also reported that dronedarone reduced the risk of stroke, even in that subgroup with permanent atrial fibrillation.
You know, you and I have discussed earlier about my experience with dronedarone. I actually like it, and it's sort of taken a beating in the press lately. But I use it in patients that are sort of virgins in the atrial fibrillation world. I present the patients with the option of amiodarone. When they hear the side effects, they actually want to utilize dronedarone, and I've actually had pretty good luck with the patient staying on the medication. But you have a different experience because you pointed out that you have patients that have had multiple drug failures. So how do you feel about dronedarone, and where do you find its place?
Well, in my experience, most of the patients I see who are referred to me are patients who have often already been tried on an antiarrhythmic drug. And dronedarane's efficacy for preventing atrial fibrillation is modest. It's equivalent to the other common agents that we use, propofenone, flecainide, and sotalol. So it's not surprising that my experience would be different from yours, that if a patient has already failed one of these other three drugs, that the likelihood that dronedarone is going to be beneficial for them is probably lower than the so-called virgin patient you're describing who has never been tried on an antiarrhythmic drug.
Mm-hmm. My patients actually seem to stay on it fairly well. I know that there is a significant incidence of GI upset, and have you found that as well?
Yes, we've noticed that a number of patients experience GI upset, and for that reason we have had to stop it.
I've had a little luck by asking them to start out by taking it on a full stomach. Dronedarone is something that I think patients are really, they very much utilize Google, they research things, and I know that there's been some concern about liver dysfunction. Have you found that to be an issue?
In my experience, we haven't seen significant liver dysfunction, and we just recommend to physicians, like with amiodarone, that they monitor liver function or monitor liver enzymes every 6 months. And obviously, if you see abnormalities, then you'll have to consider stopping the medication. But in fact, the cases of severe liver failure that were initially reported, in the next number, I think it was in an additional 200,000 patients, there wasn't that incidence of liver failure that was observed. So I think it's relatively infrequent, and with careful monitoring, as with any drug therapy that has potential toxicities, hopefully we're going to avert significant problems.
You know, based on past experience with antiarrhythmics in patients with impaired LV function, I've been very careful to not utilize this medication in any patient that had even LV systolic impairment to any degree. You know, they have to have a pretty pristine EF before I'm going to utilize it. But actually, the contraindication states a prior history of failure, I think, doesn't it? That doesn't just speak about congestive failure or also LV impairment. I mean, there's a difference, it seems, in the recommendation.
Well, the study in heart failure patients where dronedarone was observed to increase risk of mortality, predominantly due to worsening heart failure, was in a very sick population. And certainly the drug is contraindicated in such patients with unstable, poorly controlled heart failure. But by extrapolation, I think if we look at the principles by which we select antiarrhythmic drugs, we're very reluctant to use any of the class 1 or class 3 drugs with the exception of amiodarone in patients who have significant structural heart disease. And in the instance of dronedarone, we need to remember that it's also a sodium channel blocker as well as having effects on other ion channels. And it may be that one of the reasons we've seen the adverse effects reported in the PALLAS study is part of the increased risk of death was due to arrhythmic death, and it may have been due in part to the sodium channel blocking effects such as were reported in the CAST trial a number of years ago. As well, dronedarone has an interaction with digoxin, and the investigators were advised to monitor digoxin levels. But whether an interaction between dronedarone and digoxin was also a factor in causing an increased risk of arrhythmic deaths is uncertain at this point.
So back to the focus of the patients in the PALLAS trial, which were persistent AF patients. How do you approach that patient? And the reason I ask that question is I've spent the last 20 years trying to get those heart rates down, and now we have data that say that maybe those patients are suffering adverse events from bradycardia. So how do you approach the patient, and what cocktail of medications do you start with?
Well, guidelines for heart rate control have changed a little bit based on the RACE-2 trial, which was a randomized trial of a lenient versus a strict rate control strategy. And the current guidelines recommend that rate control goals should be a heart rate of less than 110 beats per minute at rest. The Canadian guidelines are slightly stricter. We recommend a resting heart rate at rest of less than 100 beats per minute, and the rationale for that was that only 20% of patients in the RACE-2 trial actually had heart rates between 100 and 110. And as electrophysiologists, we're always concerned about the risk of tachycardia-induced myopathy if the heart rate is too high. But I think a goal of 100 beats or less at rest is a good starting point. And I agree, trying to achieve too strict a heart rate control may result in the need for a pacemaker, which is obviously a goal we'd like to avoid unless the patient really needs it.
Sure. And several health plans now are rescinding their payment and coverage for dronedarone. How do you feel about that? And do you think dronedarone does have a role in the pharmacologic management of patients with AFib? Or do you think we have better things, or should we just forget it altogether?
We have limited drugs to manage patients with atrial fibrillation. And patients in whom we initiate rhythm control, it's because they're usually quite symptomatic. So if we eliminate a drug that has been shown to date to be safe in patients without significant structural heart disease, then I think we may be limiting our arsenal too narrowly. So the drug has been shown to be of benefit in patients for prevention of atrial fibrillation, and personally I'm going to look at it as a possible alternative in that group of patients who don't have significant structural heart disease. But I have no intention of using the drug in patients who have had a previous myocardial infarction or who have impairment of systolic ventricular function.
As I said, I've had good luck with it so far, and I appreciate having the opportunity, to have another choice besides amiodarone long term, especially in patients that are young, because I see so much thyroid dysfunction with amiodarone on the long haul. So thanks very much for talking with me tonight. I really appreciate your coming. It's been a pleasure, and thank you very much for joining us and the heart.org. Thank you.
Thank you,
Thanks
Melissa.
for coming.
My pleasure.
Appreciate it.